So, Kavita, if I heard you correctly, you didn't seem to believe that any of these models were going to necessarily reduce cost. It seems like they may improve quality.
No, I think they can reduce cost. I just don't think they're going to reduce. I think that we've had the idea of what we had thought, including myself, many people in the early phases of the OCM thought it was really attacking kind of unnecessary inpatient costs, unnecessary admissions, unnecessary emergency room care. All of that is true and true and true. However, like I certainly didn't think that the drug costs would be the overwhelming, and shame on us for that. So I do think that these models can reduce costs, but you have to understand, like a doctor does or any clinician, the underlying root cause of things. You can't just look at the symptoms. So I think that what we've been doing in payment models is looking at the symptoms.
So if we're going to reduce cost, and cost is being driven by drug in this population, so not all healthcare populations, but in this population, are we moving towards more and more companion diagnostic driven or molecular targeting? So even we talk about IO, PD-L1 won't be it, and tumor mutational burden won't be it. And we're going to have to go beyond that to identify who are the most appropriate populations.
Yeah, so I mean, appropriate utilization is kind of key, and there are certainly clear examples where there's kind of a right or wrong. So HER2-positive breast cancer, for instance, there's a clear right or wrong when trastuzumab is appropriate or not. Unfortunately, we don't have that for a lot of our therapies. We don't have data regarding what's the optimal duration of therapy. Do we need a year of IO? Do we need 2 years of IO? When can we stop? And as those, we're talking, $150,000 a year for some of these PD-1 antibodies. Do we need the year? And if drug costs are really what's driving kind of the rising costs of cancer care, which it is, maybe that's an area where we do have to focus.
So Ted, you brought that up, that if everybody's got to play, everybody's got to be a part of this. But historically, for those trials to be done, pharma's got to do those trials. And yet right now they wouldn't be they're not in their business best interest. So does it happen or does it not happen?
Oh, well, I'll tell you right now, if you look at the landscape in D.C., whether you're talking about either side of the aisle, and actually in many respects more on the Republican side, look at what the administration has done. They are literally after drug prices. And hook or crook, it's basically going to happen. And I think that the industry has had a little bit of a wake-up call, but I think has to have more of a wake-up call in terms of this is going to happen, because the days of going after the oncologist to basically get to the drug companies, those days are over. And so the problem is we do have unsustainable costs, but also you have to look at the mix of costs. Again, I go back to what I said before. If you look at the OCM, basically Part B costs have gone up 26%. If you look at Part D, it's 280%. So we have an issue there, and as you know, and we've talked about this before, 30%, 35% of the pipeline, of the pharma pipeline, are oral drugs. So we have a whole nother issue there, and that gets us into a whole nother complication. And by the way, I've said this before, and I'm sure Kavita would be disappointed if I didn't say it. You've got confounding factors like 340B in terms of discounts. You got PBM rebates that basically complicate this whole model in terms of drug prices.
We have 5 minutes left, and you saved that till now.
Absolutely.
I'm not sure I'm proud of you, or you managed to work in it again.
No, it's just discipline. Discipline, Bruce.
So Rich, it sounds like, what as a clinician, the hope and prayer would be that we don't have kind of a wholesale approach, where one size fits all, and we're just going to, when we can't agree, we'll just take 10% off the top of everything, and that becomes a solution. Rather, it's going to be, let's be smart about it. Maybe let's do the studies. Maybe we can get by with 6 months instead of a year, 1 year instead of 2. And we've seen some of it, right? Because, and sometimes it's driven by toxicity. In the case of combining CTLA-4 with PD-L1, it was found to be that the more expensive drug can be given in a lot lower dose and still get bang for that buck. But it sounds like we're also going to need the data to say we've got long-term benefit here. And that means also a change in the model from the short term. So guys, this was great. I wanted animated delivery and a lot of crosstalk, and we had it. 30-second final thought, Susan?
Keep the patient first.
30 seconds, really.
Just say 340B. We'll be done.
340B, PBM, rebates. No, I think that basically all the stakeholders here have a stake in this, making it successful. I think OCM has been a success in part, but we've got to go to 2.0 and 3.0 and beyond.
Kavita.
Yeah, we need to find a way to engage more hospital and kind of hospital-based facilities. There was meaningful participation, but I think that the beginning of the promise of all of this, it has to kind of be all in. So.
Yeah, and I think that, I mean, the foundations have been really set with OCM 1, and it's just a question of can we build upon that.
Thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this discussion to be useful and informative.